Well, thank you so much. My presentation today is titled Non-Opioid Therapy for Third Molar Extractions. No financial disclosures. I will be speaking a lot about Exparel from the company Pacira, but I have no relationship with them. Quick thank yous. So my how I do it is actually just modifications from my colleagues. I try to pick giants and then stand on their shoulders. So specific thanks to Austin Ivy in Colorado and Danielle Gill in South Carolina. My practice is pretty youngish. It's less than 4 years old, a scratch startup. It's important to me that I had a practice which was very outcomes-based and quality-based. And I also wanted to have an experience that the patients don't dread third molars. Unreasonable Hospitality was a book which really resonated with me, and so I made it one of our core values. My thought process for a young practice was that if we create a better experience, then your practice can get built faster and better. The extension of this is kind of an extended recovery after surgery, so an ERAS approach. So that's the protocol that we're trying to use for extraction of third molars. Part of that is to have a kind of a reduction in opioid use. And for me, specifically, my goals would be less pain and swelling after third molars, and then also fewer complications, fewer instances of infection and dry socket. So in our world, we do a lot of third molars. I don't think I need a citation for that. But is there an opportunity for us to have better outcomes? And then also, will patients accept that plan? So in one slide, my how I do it is PRF, so platelet-rich fibrin, and then liposomal bupivacaine or Exparel. Platelet-rich fibrin. So here's a very simple slide on PRF. I'm not going to dissect the differences between the alphabet soup that is APRF or LPRF or IPRF. Essentially, I use the Shukroon protocol, spinning an 8-minute spin, 13,000 RPMs. Platelet-rich fibrin should be rich in platelets. Should also be rich in growth factors and leukocytes. The goals for me, so faster healing, less swelling from those growth factors, less likelihood of dry socket from that platelet plug, less chance of infection from our leukocytes and white blood cells, and then additionally, there's a physical barrier in your sockets, so less chance of food impaction. There are studies available in our literature. I'll be the first to tell you that there's no consensus on these things, but there are advantages shown to this as well. And then Exparel. Simply put, it's a slow-release local anesthetic. Reportedly from the manufacturer, it lasts up to 5 days. My experience is closer to 3 days. We anecdotally see a small jump in phone calls at day 4 after thirds. The obvious goal is that if a patient is locally numb, they're going to have overall less pain. This is not a block, so we're not getting patients' lips or tongues numb for 3 days. My experience is that the numbness is not profound. So I remember a case who came back later in the day because they had some bleeding, and I was able to suture them without having to renumb that patient. But the patient themselves did not say that, hey, I really feel numb or anything like that. The other part of this is that you're using a moving needle technique, so you are injecting deeper and then slowly depositing as you pull out. So these liposomes do not infiltrate. They will sit wherever they're placed, and you will need multiple injection sites, and we'll show some of those pictures later. You do need to use a 25 gauge needle or something larger bore than that for the liposomes to fit through. Anything smaller and you're going to get premature bursting of those micelles. Refrigeration, this is a liposome. It's a spherical sac phospholipid, so it is a fat, think propofol. So there is an infection risk that exists for this. So the guidelines say that once the drug is drawn up, you need to use it within 4 hours. Additionally, you can't mix it with other non-bupivacaine local anesthetics. So if you've injected lidocaine, you are instructed to wait 20 minutes before you can use Exparel. And again, we have data. This is Pacira's data, and then also within our own literature, we have it as well. To be fair, there's also other reports out there which don't show a huge advantage of Exparel use either, or a reduction in opioid usage. So my consultation, this is exactly what I say to patients. So everybody probably has a third molar script, and we add this into it. So one thing we like to do is draw blood after we get your IV. We spin it down in a machine called a centrifuge. This removes the red blood cells and leaves us with your plasma. The plasma has a lot of good stuff, things including growth factors, platelets, and white blood cells. We then take this plug and put it in the sockets after the extractions on the lowers. This allows things to heal up a day or two faster, and we have fewer complications, things like infection, and fewer complications of something called a dry socket. We also like to use a long-lasting numbing medication, which can last for up to 3 days. This means you'll have less pain and lets us avoid using narcotics. We also expect you to get back to work or school a day sooner by doing this. Some of my observations from this is that you'll get a lot of head nodding. A lot of these 16, 17, 18-year-olds come with their parents. You'll get a lot of head nodding from the parents, and I think they do really like the idea of not having to use opioids or narcotics. There's also a wow factor that I see with people's eyes light up when you kind of explain to them and educate them what PRF is and how it works. I do let patients know that this is optional. I'm not pushing on it. I'm not telling this is mandatory. My treatment coordinator also does the same thing when she's presenting fees. A lot of people have asked me about what codes we use for this. So these are the CDT codes in 9613. And then for the PRF, we use a 7921. We charge $100 per site for the Exparel, and we charge $50 per site for the PRF. And just my brain trust of colleagues that I ask, I do have some of our colleagues who are charging about $800 for a set of thirds or $400 per site. And I do also have colleagues who just charge for their hard costs for Exparel, which may come out to be $100 per case. So for the purposes of this presentation, I tried to collect my data over the past 6 months. I'm no researcher, but I can do some simple, straightforward math. So over the past 6 months, I saw 165 patients who required a lower third molar to be taken out. This was local, this was sedation, this was a single tooth if they're just coming in for an isolated tooth or if they're coming in for all 4 thirds. And I presented my PRF and Exparel plan for all of them. Of the 165, 137 of them opted in for an acceptance rate of 83%. I started doing this about 3 years ago, and I think that's a little bit higher than I would have expected. I do think that there's a lot of people who say, hey, it's not covered by insurance, and I wouldn't go for it. But I think if you present to them the advantages to something like this and explain to them the value, then people will accept treatment. And then the actual, finally, how I actually do it. So we start by getting venous access. For sedations, we're already getting an IV. For locals or nitrous, we're doing a butterfly. Notably, this is going to add a few minutes to your start time. We immediately start the centrifuge process right after that. Localizing the patient is a little bit different than my traditional method for doing this. So for an IAN block, I will use lidocaine and bupivacaine, but for the long buccal, we're only using bupivacaine because you would otherwise have to wait 20 minutes before you can give the Exparel. A point for how I do it, I do not use PRF and Exparel in 1 and 16. There are plenty of clinicians who do. I did for a while, but I didn't find it offering very much, and especially since our post-op issues are almost exclusively on the lowers. So after you do your extractions, curette, irrigate, I'm ready to place PRF, compress it into the socket with a piece of gauze or a sponge. I do place a gel foam over that and compress that with the sponge as well, and then oversew that with 3-ochromic gut. I do use 2.5 cc's of Exparel per site. So for a set of thirds, I'm doing 5 cc's total. The vial is 10 milliliters. A lot of this was developed for knee and back surgery, and so they do have larger vial sizes. And I am going to be using it off-label by splitting it among multiple patients. It is a single-use vial. I also try to do 8 to 10 injection sites in the long buccal area. So this diagram is from Dr. Lieblich's paper, and so he does have the numeral 4 there. He's got 4 injection sites. I try to double that, and then have a less amount deposited in each site. I feel that we can get a larger area that way. Notably, this also adds another 2 to 3 minutes to your process per side. So if you are somebody who is trying to gain efficiency, this will make your cases a little bit longer. All right. And then again, just the purposes of the data that I have, again, an N of 165. My metrics aren't necessarily the greatest. I did measure post-op phone calls and post-op visits without actually identifying what the reasons for them were. So in the group without PRF and Exparel, we had 4 post-op issues for a total of 14%. And in the group with PRF and Exparel, we had 16 issues for a total of 11%. I would be the first to admit that it's probably not significant, and I do find an advantage still. I think if I had better metrics, if I could isolate isolate, hey, somebody calling just to see if this is normal, or if somebody's coming in just to make sure they're okay before they go on vacation, we might see some differences in that. Additionally, there are 0 documented dry sockets in either of these groups and 0 opioids called in for either group. And so the question is begged that, hey, why even do this if you're not prescribing opioids? And I would like to say that I do think we do see a better recovery for the PRF Exparel group if I had looked at the length of time of recovery, the duration of pain, overall swelling, and then actually measured those complications as well. I was sharing my disappointment with one of my colleagues in the exhibit hall, and somebody overheard and came up and kind of said to me, hey, ever since we started doing PRF, we've had a drastic reduction in phone calls and complications, and I kind of have that same experience. I know anecdotal is not as good as measurements and data, but I think intuitively we all feel that this is helpful. And then just to end this, people always ask me about the revenue for this. How do you charge, and how much does it generate anything? I'll be the first to admit I don't do this to gain revenue. The 10 cc vial does cost $200. If you try to include all your phlebotomy tools, you'll probably come out to be about $55 per site. I did 12 months worth of gross revenue, and you're looking at about $62,000 that we collected, and then net revenue after that. Those cost about $40,000 over the course of a year. So not a huge generator of income, but it is still sizable. I don't have a handout. It is available if you want to email me. I'm happy to answer any questions at the end too. Thank you.